Hello everyone, my name is Zoya. Welcome back to another one of PIMG's free medical lecture videos. This is the biochemistry section. We'll be discussing the B vitamins in this lecture. So these are the B vitamins that we will be covering in this lecture. I cannot emphasize enough on how high yield these vitamins are, so please pay attention to this lecture video. Hopefully, getting to know these vitamins inside and out will award you free points on exam day. So let's begin with vitamin B1. This is also known as thiamine. It's important that you familiarize yourself with the vitamin B and then the number as well as the associated name. So B1 again is thiamine. You can think of the I in thiamine as 1. This is a cofactor for 4 of the dehydrogenase enzymes, and a mnemonic I use to remember them is PBAT. Now PBAT stands for pyruvate dehydrogenase, branched chain keto acid dehydrogenase, alpha ketoglutarate dehydrogenase, and transketolase. Hopefully you've seen these enzymes before while studying for biochemistry. These come from pathways such as the glycolysis pathway, Krebs cycle, and the HMP shunt. Now deficiency in thiamine means that your body is unable to break down glucose, and this depletes your ATP. So tissues that are in organs such as the brain and the heart will be affected first, as they primarily use aerobic glycolysis to get their energy. For patients that have thiamine deficiency, you do not want to give them glucose or dextrose before you give them a thiamine infusion, because this will actually worsen their condition. Because you don't have thiamine to break down the glucose, giving the glucose will just obviously make it worse, and one of the associated conditions that we will be talking about is known as Wernicke's encephalopathy. We'll get into that in a bit. Now, thiamine deficiency is common in alcoholics and patients with malnutrition. So vitamin B1, thiamine, is associated with 5 conditions. These are called Wernicke's encephalopathy, Korsakoff syndrome, Wernicke-Korsakoff syndrome, which is essentially a combination of the two. You also have dry beriberi and wet beriberi. So Wernicke's encephalopathy is a triad of neurological symptoms. This includes confusion, reversible ataxia, and ophthalmoplegia, which is essentially abnormal eye movements. This condition can be life-threatening. It has an acute onset, and diagnostically you will see an increase in transketolase within the RBCs after you administer the patient with thiamine. Korsakoff syndrome is a triad of permanent memory loss, changes in personality, and confabulations. Confabulations are essentially lying when not realizing that you're lying. So these patients will be found to make up stories which seem to be truthful, but in fact they are lies, and the patient does not realize they're doing this. This one is associated with chronic alcohol use. Wernicke-Korsakoff syndrome, as I mentioned, is a combination of the two. So the patients will present with symptoms from Wernicke's encephalopathy as well as Korsakoff syndrome. And this is due to damage to the mammillary bodies and medial dorsal nucleus of the thalamus. These points are important to remember for your exam. Wet beriberi, you can think of wet as blood. So in wet beriberi, you will see a high output cardiac failure due to dilated cardiomyopathy, and you will also see edema. Whereas dry beriberi is involvement of the nerves, not the heart. So you will see neurological symptoms such as symmetrical wasting of the muscles and polyneuropathy. So for example, the patient can present with foot drop as well as wrist drop. Next, we have riboflavin, which is vitamin B2. This is an essential part of FMN and FAD. You have probably seen these cofactors within your biochemical pathways. These stand for riboflavin 5-phosphate and flavin adenine dinucleotide. These cofactors are important in redox reactions. The one enzyme I need you to remember for this vitamin is succinate dehydrogenase. This is found in the Krebs cycle. A good memory hook for you to remember it is ribs suck when dehydrated. You obviously don't want to eat dry ribs. You want them to be juicy. So ribs suck when dehydrated stands for riboflavin and succinate dehydrogenase. Also, instead of saying riboflavin, you can try saying biboflavin. Bi stands for 2, so therefore riboflavin is vitamin B2. The third memory hook helps me remember the symptoms associated with riboflavin deficiency. So deficiency can cause vascularization of the cornea, I suggest you search up a Google image on that so you're familiarized with that. You can present with stomatitis, anemia, and chelosis. I thought chelosis was the most high yield here, so I've added a picture for you. This is essentially fissuring and swelling of the lips. You have painful lesions in the corner of your lips, and these result in bleeding. So the way I remember this is I eat corn with my ribs, but it swells my mouth. So clearly this patient has, or this person has issues eating corn with his ribs. I don't know. But corn stands for corneal vascularization, rib for riboflavin, and swells my mouth can remind you that this involves chelosis. Next is vitamin B3, also known as niacin or nicotinic acid. Niacin is an essential component of NAD+ and NADP+. These are two cofactors also used in redox reactions. Niacin is used to treat dyslipidemia, but it is not the first-line treatment. As you will see, it has many side effects, but it treats dyslipidemia by increasing HDL levels and decreasing VLDL levels. You will get more into these when you study your GI videos, but HDL stands for high density lipoprotein, VLDL is very low density lipoprotein. As you may have heard, there is good cholesterol, bad cholesterol. They're usually talking about HDL as the good cholesterol and LDL as the bad cholesterol. So another thing that you need to keep in mind for vitamin B3 is that it needs vitamin B2, which was riboflavin, and vitamin B6, pyridoxine, which we'll study in a few more slides. And these two are required to synthesize B3. You can think of these two vitamins as 6 divided by 2, which equals 3, so that's a good way to remember it. Another thing that's essential for vitamin B3 is tryptophan, as tryptophan is what is synthesized into niacin. So deficiency in tryptophan can also cause a deficiency in vitamin B3. Same with vitamin B2 and B6. Deficiency in any of these two vitamins can lead to a deficiency in vitamin B3. So this is something you need to remember for your exam day. So let's get into the symptoms associated with vitamin B3 deficiency. So you can have severe deficiency, which is known as pellagra. Pellagra has 3 D's to remember. You have dementia, dermatitis, and diarrhea. You also get glossitis in vitamin B3, but remember these 3 D's, and then remember that it can also lead to death. Now, dementia can be associated with hallucinations, and the dermatitis for niacin deficiency is very specific. So this is known as the broad collar rash, and I will show you a picture shortly, but this is in a distribution from the dermatome C3 and C4. So hyperpigmentation also occurs in sun-exposed areas, and severe deficiency, known as pellagra, can be due to decreased tryptophan absorption from the GI enterocytes and the proximal renal tubule transporters. This specific condition is known as Hartnupp's disease. So you just need to remember Hartnup disease is the autosomal recessive disorder, and this is defined by a decreased neutral amino acid absorption. As you know, tryptophan is a neutral amino acid, and you have decreased absorption, which means there's not enough tryptophan to synthesize into niacin. So the way you treat patients with Hartnup disease is to give them niacin supplementation and a high protein diet. Now, another thing that can cause deficiency of niacin is malignant carcinoid syndrome. So this increases tryptophan metabolism, so you don't have enough tryptophan left to make into niacin. The other vitamins we've covered, I haven't really talked about excessive vitamin B1 or B2, but vitamin B3 excess is important to remember. It causes a condition known as podagra, okay? And it's usually because you're using niacin to treat dyslipidemia. So if you have excessive niacin supplementation, you can develop podagra. This could be facial flushing, hyperuricemia, hyperglycemia. Facial flushing in vitamin B3 excess is due to prostaglandins, and this is a very important point to remember and understand because patients are pre-treated with aspirin before given niacin, and this is because aspirin is a prostaglandin inhibitor. You can also get hyperuricemia, can present as gout, and you can also get hyperglycemia with niacin excess. The pictures you see on the right here, this is the dermatitis that I was talking about, the broad collar rash in the dermatome C3 and C4. A memory hook to remember are the 3 Ds for deficiency. So dementia, dermatitis, diarrhea, and the 4th D could be death. But 3 Ds helps me remember vitamin B3 and Ds for the 3 dementia, dermatitis, diarrhea symptoms. Now, vitamin B5 is known as pantothenic acid. Pantothenic acid is part of coenzyme A, and it's necessary for fatty acid synthase and acyl transfers. So CoA is a cofactor for many metabolic reactions. This can include pyruvate dehydrogenase, which is an enzyme, and it makes acetyl-CoA from pyruvate in coenzyme A, and it's necessary for the TCA cycle, fatty acid synthesis, and cholesterol synthesis. Deficiency in vitamin B5 can lead to alopecia, which is loss of hair, dermatitis, enteritis, which can present as diarrhea, and you can also get adrenal insufficiency. So I think this is kind of unique to B5 deficiency. You'll see that there's another vitamin that presents with alopecia, dermatitis, and enteritis as well, specifically biotin. So you should know that B5 deficiency also has adrenal insufficiency. You can present with burning feet syndromes and distal paresthesias. Now, vitamin B6. This is also known as pyridoxine. Pyridoxine is required for transamination. These are your liver enzymes such as AST and ALT. But first, pyridoxine needs to be converted to PLP, also known as pyridoxal phosphate. Pyridoxine is also a cofactor in glycogen phosphorylase and decarboxylation reactions. Pyridoxine is also needed to synthesize heme, niacin. As we mentioned, vitamin B3 requires vitamin B2 as well as B6 to be synthesized. Vitamin B6 is also used for histamine synthesis, glutathione synthesis, and neurotransmitters such as norepinephrine, epinephrine, serotonin, GABA, and dopamine. So if you know the function of these substances, you can kind of presume what kind of symptoms arise from vitamin B6 deficiency. One of these symptoms is peripheral neuropathy. Now, vitamin B6 is responsible for making ceramide, which is a component of myelin. Vitamin B6 also presents with a specific type of anemia known as sideroblastic anemia. So I've included a picture on the right here just to show you what sideroblastic anemia looks like on histology. Vitamin B6 deficiency can also present with convulsions, hyperirritability, and an important factor to know is that vitamin B6 deficiency can be caused by the use of the drug isoniazid and also with oral contraceptive pills. So sideroblastic anemia, if you guys are not familiar with it yet, is when the bone marrow cannot produce normal RBCs, and this is not because you don't have enough iron in the body, it's because you cannot make hemoglobin properly despite normal iron levels. Vitamin B7, also known as biotin, is used for carboxylation enzymes. So a good way to remember this is through my Memory Hook 7 Carb app. 7 helps you remember that it's vitamin B7 that we're talking about. Carb is for carboxylation, and app is the mnemonic for the enzymes involved. So these are acetyl-CoA carboxylase, propionyl-CoA carboxylase, and pyruvate carboxylase. Remember back during the vitamin B5 slide, we talked about another vitamin that has similar presentations with its deficiency. So that is this vitamin. Vitamin B7 also presents with alopecia, dermatitis, and enteritis when you are deficient in it. Deficiency of vitamin B7 can be caused by ingestion of raw egg whites, and this is due to a protein present in raw egg whites known as avidin. Now, when you cook these egg whites, you can denature the avidin, and so it does not affect you or cause vitamin B7 deficiency. Another point to remember is that carboxylation adds 1 carbon to the substrate. So when it's used with these enzymes, for example, acetyl-CoA carboxylase, then it adds a carbon to acetyl-CoA to make malonyl-CoA. So it goes from 2 carbon acetyl-CoA to 3 carbon malonyl-CoA. The second last vitamin we'll be covering in this video is vitamin B9. It's also known as folate, and folate is needed for a 1-carbon transfer or methylation reactions via folase conversion to tetrahydrofolate, and this is required for making DNA and RNA. Recall that in pyrimidine synthesis, the last step from DUMP to DTMP requires tetrahydrofolate to turn into dihydrofolate in order for that reaction to happen. Deficiency of folate is usually seen in alcoholics and in pregnancy. Recall from your studying that folate deficiency can cause neural tube defects, which is why it's recommended that anybody that's trying to conceive should start taking folate supplements at least 1 month prior to conception, and it should be given through the entire 9 months of pregnancy. Folate deficiency can present with megaloblastic anemia. It's macrocytic and it's like B12 deficiency. You will see hypersegmented polymorphonuclear cells on histology, and I will show you a picture on that later. B12 deficiency also has a few other differences that you need to keep in mind, and most likely because these two both present with megaloblastic anemia, you'll be tested on either of the two on your exam day. B9 deficiency can also cause glossitis, and there are some drugs that can cause B9 deficiency. So these are methotrexate, TMP, sulfonamides, and phenytoin. Labs will show normal methylmalonic acid, but increase in homocysteine levels. So keep in mind that folate deficiency has normal methylmalonic acid, but increase in homocysteine, whereas B12 deficiency will present as an increase in both methylmalonic acid and homocysteine levels. Other points to remember is that folate is stored in the liver. The stores in the liver are not that big as compared to B12. Folate is absorbed in the jejunum, unlike B12, which is absorbed in the terminal ileum. And folate is found in leafy green vegetables. Lastly, we have vitamin B12, which is also known as cobalamin. Cobalamin is needed for the enzymes methionine synthase, methylmalonyl-CoA mutase, as well as for DNA synthesis. Cobalamin transfers methyl groups by working as methylcobalamin. So deficiency in vitamin B12 can lead to paresthesia. You have degeneration of the spinocerebellar tract, the lateral corticospinal tract, as well as the dorsal column. If you're not familiarized with what these tracts are responsible for, I have a little bit of a review here, but you make sure that you go through these. So your spinocerebellar tract is responsible for proprioception. So these patients will present with ataxia. One of the tests you can do to test this is called the Romberg's test. And if it's positive, that means when they close their eyes, they're swaying back and forth and unable to stand upright. Then the lateral corticospinal tract is responsible for voluntary movements of the contralateral limbs, whereas the dorsal column is responsible for fine touch, vibration, pressure, proprioception from skin and joints, and 2-point discrimination. Unfortunately, prolonged B12 deficiency can cause irreversible nerve injury. Like B9 deficiency, B12 deficiency can lead to megaloblastic anemia, but unlike B9 deficiency, you have an increase in homocysteine as well as methylmalonic acid levels in B12 deficiency. If you recall, in B9 deficiency, only homocysteine levels were increased and methylmalonic acid levels were normal. So you can have concurrent folate and B12 deficiency. Sometimes if you give patients with B12 deficiency folate supplementation, it may mask their megaloblastic anemia symptoms. However, the neurological symptoms will still persist. One of the causes of B12 deficiency is infection with a parasite known as Diphyllobothrium latum, and this can cause malabsorption of B12. Some of the other causes can be surgical resection of the terminal ileum. So remember, B9 was absorbed in the jejunum, whereas B12 is absorbed in the terminal ileum. And usually during Crohn's disease, people may have to get surgical resection of the terminal ileum, and this can lead to B12 deficiency. Other malabsorptive states such as celiac sprue, bacterial overgrowth, excessive alcohol, achloridria, and enteritis can also cause B12 deficiency. You may be lacking an intrinsic factor due to a gastric bypass surgery, or due to pernicious anemia, you can have vitamin B12 deficiency as well. People that are usually on vegan diets, they can become deficient in B12, but this takes a very long time because unlike folate, you actually have a very large pool reserve in the liver for B12. Lastly, metformin use can also cause B12 deficiency. I have added these histologic slides of megaloblastic anemia so you guys are more familiar with what it looks like on histology in case they give you pictures on exam day. So as you can see, these are polymorphonuclear cells with hypersegmented nucleus. So you can see it has multiple lobes. On the exam day, they may also give you the MCV, and that is usually increased. So that is all. These are my references. Now this is a great quote that is good to live by. It is better to sit alone than in company with the bad, and it is better to still sit with the good than alone. So you will come across a lot of people that are putting you down in this process. Studying for step 1 itself is very difficult, so just make sure you're surrounding yourself with good company, and if you're unable to find good company, it's better to just, focus on yourself and ignore what other people are saying. Don't let anybody discourage you. You guys got this, and good luck.